Welcome to the Neurostimulation Podcast. I'm Michael Passmore, Clinical Associate Professor in the Department of Psychiatry at the University of British Columbia in Vancouver, Canada. The Neurostimulation Podcast is about exploring the fascinating world of neuroscience and clinical neurostimulation. We look at the technology, how it works, what are the latest research breakthroughs, and importantly, how those research breakthroughs are being translated into treatments that can improve health and well-being. I want to also emphasize that this podcast is separate from my clinical and academic roles and is part of my personal effort to bring neuroscience education to the general public. Accordingly, it's important for me also to emphasize that the information shared here is intended for educational purposes only and not as medical advice. If you have specific questions that pertain to your own health, I would really encourage you to consult a professional, whether that's a doctor or other professional in the healthcare area, to get tailored and specific answers to your questions and to ensure that you have a professional and comprehensive evaluation. Today's episode is presented by ZipStim Neurostimulation. ZipStim is the clinic that I operate. You can check us out at zipstim.com. That's zipstim.com. In this episode, we're going to be discussing the next chapter in the important textbook on transcranial direct current stimulation. So please stay tuned. I think you're really going to get a lot out of this episode. So today we're taking a comprehensive journey into the biophysics behind one of the most accessible and exciting non-invasive neuromodulation techniques in clinical neuroscience today, transcranial direct current stimulation, or tDCS. Today's episode is going to be based on Chapter 2 of the textbook Practical Guide to Transcranial Direct Current Stimulation. This is a foundational reference for clinicians and researchers alike. So whether you're a seasoned neuromodulation specialist, a student, a curious clinician, or just someone who's interested in how this technology works and how it might be helpful for you, a friend, or a family member, we're going to unpack together how tDCS works. We're going to start with a look at the physics, diving into the physiological effects, and ending where this fascinating field is headed. Let's start with segment 1, the essence of tDCS. This is simplicity with subtle power. We're going to begin with a bold claim. tDCS is powerful because it is simple. While other neuromodulation techniques like transcranial magnetic stimulation, or TMS, or deep brain stimulation, DBS, require complex equipment and intense electrical or electromagnetic pulses, tDCS relies on a low amplitude, constant electrical current, typically between 1 and 2 milliamperes, delivered through scalp electrodes, so non-invasively. It doesn't make neurons fire directly, but it makes them more or less likely to fire. This essentially makes tDCS a priming tool. It enhances or dampens the brain's existing patterns of activation. If you apply it before or during a task, for example, in motor rehabilitation or training of working memory, it may improve the effectiveness of that task by modulating the underlying cortical excitability and plasticity. And here's the key word, subthreshold. Well, there are two keywords really, non-invasive and subthreshold. So tDCS does not involve any invasive procedure into the body or brain. tDCS also doesn't force electrical action potentials. Instead, it shifts the likelihood of neuronal firing. Think of it kind of like tuning a radio. We're not amplifying or increasing the volume of the sound, but we're adjusting the dial until you find the clearest signal. Let's move on to segment 2, where we're going to talk about the physics of electrical current flow from the skin to the brain cortex. To understand how transcranial direct current stimulation affects the brain, we need to talk a little bit about electrical fields. When electrical current flows from the anode electrode to the cathode electrode, a portion of that current is absorbed or redirected by the skin, scalp, the skull, and the cerebrospinal fluid, which is the fluid that bathes the outside of the brain and which is found inside the spinal cord and the so-called ventricles of the brain. However, a measurable fraction of that electrical current actually reaches the cortex of the brain or the actual brain tissue, enough to change the polarization tendencies of the neurons in that affected brain tissue. According to computational modeling studies, 1 milliampere of current produces about 0.2 to 0.5 voltages per meter in the cortex, depending on head anatomy and the positioning of the electrodes, which is technically referred to as the montage, how the electrodes are situated on the scalp. To give you a sense of the scale, that's about 200 times weaker than the electrical field induced by transcranial magnetic stimulation. But with tDCS, it's a continuous application of energy. And this is the sustained exposure that is what gives tDCS its unique capacity to influence neuronal membrane potentials over time. Here's a practical analogy. TMS, or transcranial magnetic stimulation, is more like ringing a doorbell, but tDCS is like gently pushing the door continuously until it eventually swings open. In segment 3, we're going to talk about neurons and how they behave under the influence, polarization, and plasticity. Let's look a little bit more carefully at neuronal polarization. So when transcranial direct current stimulation is applied, anodal stimulation tends to cause somatic depolarization of cortical pyramidal neurons, making them more likely to fire, whereas cathodal stimulation tends to cause hyperpolarization and reduces neuronal firing probability. But it's not just about whether a neuron is excited or inhibited. The direction and strength of that current affects different compartments of the neuron. Here are some examples. Anodal electrical current may depolarize the soma and hyperpolarize distal dendrites, whereas cathodal current might do the reverse. These complex patterns influence not only the firing rate of neurons, but also synaptic plasticity. This is the way that neurons strengthen or weaken their connections to one another. In fact, animal studies have shown that applying tDCS during synaptic activity can amplify long-term potentiation, which is an important underlying mechanism that's involved with memory function. And this is felt to occur especially via NMDA receptors and L-type calcium channel modulation. For segment 4, we're going to talk about what happens over time, acutely versus after effects. Now, in a single tDCS session, there will be immediate changes in membrane potential, but there's more. tDCS, at least in the studies and the current clinical guidelines for therapeutic applications, involve repeated sessions. So each session, depending on the disorder that's being targeted, each session is going to last around a half an hour, and we're going to be likely prescribing half-an-hour sessions for, say, 2 weeks. And so with repeated tDCS sessions, and especially when paired with active tasks, tDCS can lead to lasting neuroplastic changes. Examples of these changes include strengthening of motor engrams during post-stroke rehabilitation, reduced hyperactivity in cortical pain networks, and improved emotional regulation by way of prefrontal limbic circuit modulation in treatment of depression. These kinds of after effects may last minutes to hours, and with repetitive treatments, potentially longer. This is why many clinical protocols involve daily sessions over several weeks. So here's what seems to be an emerging clinical pearl based on the research that's coming out in this area. tDCS seems to work best when it's paired with meaningful activity. So, for example, if you're looking at post-stroke motor rehabilitation, if you're stimulating the motor cortex with tDCS, it seems to have an improved effect when the patient is attempting or actually moving themselves. If you're stimulating the prefrontal cortex in order to try to improve cognitive function or mood symptoms, then it might be helpful to have the patient engage in cognitive or emotional awareness types of tasks. The research is pointing in the direction of the brain responding best when it has a reason to change, when it's being encouraged to change by volitional kinds of activities that the patient is undertaking during the sessions and accumulate. The brain seems to respond best when it has a reason to change, when there is a volitional kind of activity, whether that's a cognitive activity and or a motor activity and or a mood related activity that the patient is attempting to do simultaneously. And the modulation due to the tDCS seems to be facilitating that or encouraging these changes by way of the kind of priming and potentiation that we've been talking about. In segment 5, we're going to talk a bit about dosing tDCS. Certainly, the research is pointing in the direction of our understanding that it's not one size fits all when it comes to dosing, duration of individual sessions, and or duration of courses. So let's break down the key parameters of a tDCS session. There really are 5 parameters that we would focus in on. The first is the electrical current intensity. This is typically between 1 and 2 milliamperes or milliamps. The second is the stimulation duration in a single session, and that's ranging between 10 to 30 minutes depending on the target symptoms. The third thing is the electrode placement or montage. And so where the tDCS electrodes are placed on the scalp matters enormously, because this is going to influence the underlying brain areas that are being targeted. The fourth thing is electrode size and material. So larger electrodes are going to spread the current and smaller electrodes are going to focus it. The fifth parameter is ramp time. So gentle increases and gentle decreases seems to improve tolerability, basically reducing uncomfortable side effects. Other things to consider include the electrical current density, which is the current per square centimeter, as well as the total charge, which is the intensity times duration. These parameters influence not only effectiveness, but safety and patient comfort. Researchers know that it's important to consider and report all of these in the methods section of studies. This is essential for things like credibility and study reproducibility. For clinicians, consistency matters, as well as adherence to emerging and evolving clinical treatment guidelines, and helping to ensure that we're providing the cutting-edge treatment that patients deserve. Changing even one variable like electrode size or placement may dramatically alter outcomes, so we want to be quite careful with that. In segment 6, we're going to talk about modeling, personalization, and the rise of so-called HD tDCS. Thanks to computational modeling, we can now visualize how electrical current flows through individual brains. MRI imaging-based head models show that standard electrode montages often produce diffuse current flow affecting more than just the targeted underlying brain region. This has led to high definition or HD tDCS, which uses small gel-based electrodes in multi-channel arrays on the scalp. The most well-known configuration is the 4x1 ring, where a central electrode is surrounded by 4 return electrodes, allowing much more focused stimulation. Other emerging technologies include EEG-triggered tDCS, individualized modeling based on head scans, closed-loop systems that adapt stimulation in real time. This really is the future: personalized, dynamic, and precise non-invasive brain stimulation. In segment 7, we're going to talk about historical roots, all the way from the electric fish to modern clinics. Let's take a step back for a moment and consider the amazing history that has brought us to where we are today. The use of electrical stimulation applied to the body dates back to the Roman Empire, and maybe even before that. But at least we know that in the Roman Empire, physicians applied electric torpedo fish to relieve headaches. In the 19th century, Italian physicist Giovanni Aldini, actually Galvani's nephew, experimented with galvanism on the heads of patients with psychiatric illnesses. In the mid-20th century, crude tDCS devices re-emerged under the names electrosleep and cranial electrotherapy stimulation, often without rigorous control trials. But fast forward to the year 2000, when Nitsch and Paulus published their landmark study showing that weak direct current applied to the human scalp could reliably alter cortical excitability. That experiment launched the modern era of tDCS research, and the field really hasn't looked back ever since. In segment 8, we're going to talk about mechanistic nuances and ask some open questions for future consideration. Despite decades of study, tDCS mechanisms are still being refined. Some open questions include, what's the role of glial cells, the surrounding structure that provides support and nourishment for the neurons? And what about the neurovascular unit? To what extent is the vasculature of the brain implicated in tDCS's mechanism and/or the underlying pathophysiology of the disorders that tDCS is targeting? How does individual anatomy change electrical current flow? Why do some individuals seem to respond better than others? Can we optimize the timing of stimulation in order to harness a brain state dependence kind of situation? These questions are the focus of current clinical trials, many of which are combining tDCS with things like behavioral therapy, digital health tools, or pharmacologic augmentation. In segment 9, we're going to talk about real-world potential and clinical applications. We're going to close by revisiting the clinical promise here. tDCS is being actively investigated for treatment of things like major depressive disorder, chronic pain conditions, including fibromyalgia and migraine. We've reviewed that already in previous episodes, and we're going to look into that in much more detail in future episodes. Also, stroke rehabilitation is a major active area of ongoing research and emerging clinical applications. Alzheimer's disease and other neurocognitive disorders, including, and very excitingly, mild cognitive impairment as a potential target in order to help stall or perhaps even prevent people from converting to things like Alzheimer's disease and other forms of dementia or major neurocognitive disorder, at least the neurodegenerative types. Parkinson's disease or other motor-based neurodegenerative disorders, ADHD, attention deficit hyperactivity disorder, learning disorders, addiction, craving reduction in substance use-related disorders. The list is actually expanding because of all of the potential and promise of this particular technology. It's also interestingly, perhaps not surprisingly, being used off-label for things like improving athletic performance, perhaps cognitive performance in students, and so-called cognitive hackers. This obviously raises ethical questions, but it also underscores the potential overall versatility and promise of this technology. Let's recap. What have we learned today? tDCS is elegant in its simplicity, powerful in its subtlety, and promising in its breadth. It doesn't override the brain function, it seems to be guiding it, and that perhaps is its most profound quality. We're still early overall in this story, particularly in terms of clinical applications, but by understanding the principles through rigorous research, by understanding the physics, the neurophysiology, and the overall clinical potential, we move closer to making this kind of brain modulation an everyday tool in mental health applications, rehabilitation applications, and general human flourishing. Thanks for joining me today on the Neurostimulation Podcast. If you found today's episode helpful, I really would encourage you to like, subscribe, leave comments or a review, Share this with family, friends, and colleagues. Anyone you think that might benefit from this. Tune in next time where we explore another fascinating conversation in the world of health, wellness, and neuroscience, or another interesting topic in clinical neurostimulation, whether that's an emerging research finding or more information based on the textbook that we're exploring today. Once again, I really appreciate your time, your interest, and your attention, and we will see you next time. Take care, stay curious, and be well.